Okay, so the topic of the complications in implant dentistry is a very, very attractive topic, especially because nobody lives away and nobody can stand away from complications. And I want to share with you through the presentation my experience and especially try to communicate the way that I've been solving my problems by basically avoiding them, which I consider one of the key factors. And I want you to look at this picture. From the picture on the left side to the picture on the right side, it only went by 1.5 months. And the first thing that comes into my mind is why, when I apply the appropriate technique, I used connective tissue grafting, I did my guided bone regeneration, I had jumping distance, I basically thought that I respected some of the rules that stand whenever we are doing an implant in the aesthetic zone, and everything turned out to be a failure. Especially when you recognize these cases as the one that you see. The patient actually came like the one that you see on the picture. So, total failure, assuming the fact that this was a quite apparently straightforward case. But the question that comes into my mind is why? Why? Because I failed at the decision-making process. In my opinion, one of the most common fails that we make and mistakes that we make whenever we are planning a case, especially in the aesthetic zone. Because biology is there and biology sets the rules. Sets the rules where to place an implant, when to place it, and how to place it in order to be predictable. And if you look at the literature, you're going to see that according to this 2017 European Journal of Dentistry, the complications that you can experience in implant dentistry can come from mechanical complications, technical and biological complications. The ones that we are going to see here, and me as a surgeon, is going to be standing more of the biological complications standpoint, but we will also see some cases of fractures that we had to deal with. Adverse soft tissue reactions, sensory disturbances, and progressive marginal bone loss are some of the common situations that we are going to have to face whenever we face complications. Because it's important that some of the complications that we will experience during our professional lives are avoidable, but some of them are unavoidable. Some of them will be there because of a lack of knowledge that we have, and some of them, and just a few, is going to be because of bad luck. So in my opinion, we should learn from our mistakes. We have to be self-critic and continue educating. And as life goes on, important about the complications is to assume the fact that as the time goes by, the severity increases. Because it's not the same an immediate perforation, immediate complication that we can have during our sinus lift procedure, or an early complication, and how this socket in a post-extraction socket and immediate implant placement basically developed a dry socket, or a situation where we are going to find late complications that are very, very difficult to solve. Today, fortunately, or maybe in some cases unfortunately, we are going very fast and we are doing everything in one shot. We're placing the implant, we're grafting, we're loading, we're making those implants to be in function and to stand in function as soon as possible in order to reduce the time that the patient spends in the clinic. But the truth sometimes is that small details matter in order to have good results and long-term stability. Because some of the times we need to stop the time, and this is very important. In post-extraction cases, such the one that you see, if you don't take into account the biological rules that are set, sometimes these can turn into very bad consequences. And this is why our responsibility is to follow the rules, because during this presentation I will share with you my road to failure by using intuition and only trusting on my surgical skills, or my road to success where the evidence-based protocols were the ones that I had to lean on in order to be successful. I have to say that 90% of my cases are immediate. Today, it's been proven the efficacy and also the safe procedure that represents to place an implant the day of the extraction. But that 10% of the cases we don't do immediate must be analyzed, and very well analyzed. According to Daniel Booth in 2009, we know that immediate implant placement is a safe, effective, predictable, and also a long-term stability treatment option in most of the cases. But there are certain situations where risk indicators included a thin tissue biotype, a facial malposition of the implant, and thin or damaged facial bone wall are one of the most common mistakes that we don't assume and we place our implant anyway. So, important. The same road that took you to heaven when you learn these techniques can send you to hell if you don't apply the appropriate treatment. So this is, for example, the case that I want to show you, where basically what we did was just extract that infiltrated, root cavity, and we place our implant. We place a healing abutment the same day of the extraction, and then by preserving all the soft tissue and bone architecture, we were able to represent a beautiful and balanced emergence profile. I want to share with you very quick the way that we did it with a small video. So in situations where you're going to find the possibility of doing an immediate extraction implant placement, especially when you have a multi-rooted tooth, one of the ways to reach that interseptal bone is by drilling through the roots. This is the way that I do most of my molar cases. I basically use the Marcus Root-Seller technique where I keep those roots until the end, so they will allow me to have some stability of my drill and reach that interseptal bone. Once we have extracted the roots, we already have the path, and we're going to be able to place our implant very predictably, achieving primary stability without dragging into the socket, because those roots were the ones that actually avoided to drag into the socket and to drift into the socket. Once my implant is in place, I try to do all these treatments flapless. I pack the bone into the socket, and in this case I place a healing abutment. But there are many options in order to preserve the stability of your tissues. In this case, thick tissue biotype allow me to do everything in one shot without the need of connective tissue grafting. So, pretty simple case, pretty straightforward case. In most of my cases, when I see that there is buccal wall and healthy tissue, this is the way that we should go today in 2022. We all know the osseointegration process, and as we move forward into our profession, we know that from the 1980s to 2020, basically we have reduced the amount of time that we need to load our implants because of specific surfaces treatments and many other features that our implants have. We have been able to reduce the number of complications because we are reducing the times of healing, basically. We all know that from the 3rd to 4th week, according to the biological process of the bone remodeling and new bone formation, we're going to have a weak moment where our implant stability will drop into numbers that we could never imagine. But the truth is that we can compensate that dropping effect of our primary stability by using macro designs that actually are designed in order to contain those 150 microns that we need to avoid. Those progressive and horizontal patterns of our threads will allow the implant, even in cases where the ridge is quite not stable, to reach primary stability. But not only because of the good engagement of our implant, but also because during the healing process, I will have those horizontal patterns that will keep the horizontal stability of our implant. In addition, by using quick osseointegrative surfaces, as we know, the calcium with the phosphate in addition with the collagen of the blood is the one responsible for the hydroxyapatite and the mineralization of the bone. But if our surfaces are containing those calcium ions, we are increasing and rapidly forming new bone and maturation of the bone that we need in order to achieve osseointegration and secondary stability. So let's see another case. Cases that actually let me place my implant immediately without assuming the fact that there will be potential factors that can jeopardize and can affect the outcomes. But the truth is that if we do the things right, we're going to be able to be quite predictable. In situations where we need to extract the second premolar, we're going to be able to test and we're going to be able to place our implant immediately as long as we know a technique that is predictable in order to achieve that primary stability. And whenever we are doing, especially in the upper jaw, an implant after the extraction, it's important for us to know the technique, how to achieve primary stability by sometimes getting that stability from the palatal bone. But the truth is that not always we're going to have a palatal bone available, because in some situations our implant and our fresh extraction socket will have different relationship with the socket, with the ridge. So in situations like this, where I don't have remaining bone, where I don't have residual bone where I can engage my implant, it's going to be quite difficult. In the tapered regular implant, if I'm assuming the fact that I'm going to extract that tooth and the sinus is apical and I have almost no palatal bone because it's hosted by the palatal wall, in situations like this, I find myself in the worst case scenario. But the truth is that sometimes we can achieve primary stability using the mesial and distal bone. By placing an implant that actually can engage that mesial and distal bone, you're going to be able to find primary stability and even load that implant the same day of the extraction. So, two different scenarios, two designs that are different, that are moving us forward into more risky situations, right? Because we dare to do these kind of surgeries because we have the equipment to be able to be predictable when we are trying to assume the fact that we need to achieve primary stability and engage the implant in a proper prosthetic position. So in situations like this, I still gonna have remaining socket, palatal, and buccal from my implant. Comparing a tapered regular implant, this is going to be quite different scenario, quite different story. Sometimes by using just regular tapered implants, it's difficult to assume the fact that in specific situations we're going to be able to achieve primary stability unless we place a very extra wide implant, diameter implant. But the truth is that most of the times in situations like this, we extract the tooth, we don't do anything, and we wait for the collapse of the bone. So, by placing the implant in the fresh extraction socket and achieving primary stability by engaging those threads and the mesial and distal bone, I will be able to cover that area and keep that original architecture. And also, I will have a good prosthetic position of my implant. We all know that the ideal vertical position of the implant is going to be 4 millimeters below the gingival margin. 3 millimeters of soft tissue according to zero bone loss concepts will be required in order to be able to keep that soft tissue and hard tissue around our implants. But how deep will I place my implant? Our eye usually looks at the palatal wall, but the truth is that usually the palatal wall is about 1 to 3, or lingual wall is 1 to 3 millimeters cornal. So whenever we're placing the implant, it's very important not to take into account that lingual or palatal wall in order to measure the appropriate apical and vertical position of our implant. We need to look at the buccal wall, and we're going to place our implant between 1 and 2 millimeters below that buccal wall. So that's what we did. We placed our implant, we graft, we placed our immediate loading provisional crown. That allowed us to be able to have a beautiful emergence profile. And from now on, I'm going to be the one who is going to do the next step. Remember that whenever you are doing a chair-side temporary crown, change that thought. We should move forward and we should try to aim for digital workflow. By using guided surgery and also ordering the immediate loading crown is going to save us a lot of time. This case, for example, was done in the clinic, and it took a long time to customize the height of our provisional temporary abutment, to relie the crown, and then screw the crown into position. So maybe by just placing the implant in 5 minutes, you're saving time, but you're wasting a lot of time doing this in chair side. Today, we're doing almost everything digital, and we're able to place a crown that has been customized according to the digital planning of our implant, instead of having to improvise and do it in the clinic. Today we're using even healing abutments that are customized from the digital planning of our crown. And the most apical aspect of our crown is going to be basically the healing customized abutment that is going to cover that socket and allow the tissues to heal. So this is the story that I want to tell you. This is how nice everything looks whenever we tend to standardize our treatments. In my case, I used my polycarbonate adapted to the temporary abutment. We almost didn't even use sutures, just micro sutures of 5 zeros, 6 zeros, just to connect those papillas. And we had to spend a long time, as I said before, creating that transition zone, because the transition zone is important depending on where our implant is going to be. If it's going to be more centered, I'm going to completely change the shape of my emergence profile and my connection in the transition zone, the dual zone. If my implant is placed more palatal, I will need to create a completely different transition zone in order to be able to host basically my blood clot or my graft, and also preserve the original tissues. So that's what we did. Instead of using healing abutments that can be straight or expanded, we used basically that crown, and that allowed us to have a beautiful emergence profile. After 2 months, this is what we see. Embedded into the emergence profile in soft tissue, we see some particles that I strongly recommend to remove. Otherwise, the patient is going to come with one of the particles if the patient has a microscopic electronic microscope in his house. And that's basically a picture that my patient sent me to my email one Sunday night. I found this in my mouth and I want to know what it is. So try to remove them if you see them. Basically, by using these techniques learned in safe scenarios, we can be very predictable. And as you can see, after 7 years, even the tissues have been even improving up to the point that we have some creeping, maturation of the tissues, and everything is quite stable. If we look basically at the before and after, and the planning and what we were planning, we can basically place predictably an implant in an immediate extraction and fresh extraction socket.